Welcome back to The Flush, part 2 with Dr. Parikh. We're talking about GERD, which is chronic acid reflux. Sounds like I've got acid reflux right now, but I think I'm just like still recovering from the hantavirus that you gave me. We didn't talk about hantavirus.
Not from the wine.
No. It's Chris Shaver, MD, gave me hantavirus. You gave Mary, your PA, hantavirus. You gave Katrina hantavirus.
Yes, I did.
Yeah, I know. This is what happened. I got sick. I woke up with a sore throat. And I was like, immediately, because that's what I do. I got on my phone, checked my phone, TikTok comes up, and it was like CBS News, hantavirus is on a cruise ship. And I was like, and I read the symptoms. I was like, oh no, I've got hantavirus. Announced it.
I'm proud of you because we can't be ashamed to talk about our mucus.
Yeah.
I had a really sore throat.
Open up to us about it. I mean,
That's just it. No, I had a really sore throat, and then I realized that I had a terrible mystery illness that you had, and then you
was
very
absolutely.
I mean, I think case 0 was Shaver.
It was a horrific virus.
ground zero was
Weeks and weeks
Chris Shaver.
I wanted to crawl into a coffin. And
She said, or you were like, oh, you probably have what Dr. Shaver has. You look like, did it? And then we all felt like it. Poor anybody at Birmingham Gastro that was sick. Ground zero, right there, Chris Shaver. Were you on the cruise? Did you go on the
wish. I'm not bird watcher yet. It might happen any moment.
Yeah.
In my age.
I bet
Happens for older people. No, kidding.
But I am. It does. I'm losing my voice still a little bit. I'm recovering from your hantavirus. Anyways, okay, so we're going to get into Dr. Parikh's specialty procedure. Aren't you the only one in Alabama that does this? Or there's one out there?
I think there's 1 or 2 other people doing it, but we really are running it for the whole state. We're getting referrals from out of state, honestly.
Yeah. Ooh, look at you.
We've done. Well, it's a great solution for people struggling with GERD, which is still our number 1 diagnosis. And then, I'm in my career, I've just been a fan of innovation, but using it appropriately. Much like we talk about medical myths and everything, just because there's a new cool toy or technology out there doesn't mean it's the right thing to use. And I really do try to watch technology and look for evidence-based data, evidence to say, okay, this is something we should bring to our patients to help them.
Yeah.
Or this maybe too many side effects and we shouldn't do it. And so this has been a great thing. We've done, close to 500 cases now.
Yeah.
And honestly, that's preventing 500 full out surgeries. And so it's a big deal.
Because you used in the OR?
And you've been doing them for how many years?
I went for training, I think in January or February of 2020 and had my first scheduled case for April of 2020. And we know what happened then.
Mm-hmm. We sure did.
And so the first case was delayed and probably started in the fall of 2020 sometime.
Who was your first case? Somebody in our office?
It was early on, yes. I've done it for 3 people in our office.
Okay.
I won't say their names, but yeah.
So it's stood the test of time.
Yeah.
It really has. It's been a durable procedure, which is important.
4.5 years in, yeah.
Okay, so wait, TIF. TIF is Transoral Incisionless Fundoplication.
Yeah. So you can break down the word.
That word.
Transoral is through your mouth.
Okay, thank you.
Incisionless is I'm not cutting your chest, abdomen open to work on your gastroesophageal junction. And then fundoplication is the term used to create a wrap or a tightening of that reflux valve. And that's how you get TIF.
Okay, so tell us exactly. I mean, I just said the words. I'm really proud of myself for being able to say all those words. But what is it? What are you actually doing during a TIF procedure, and how can it help patients?
So this evolved from kind of I would say both a need and a desire to create a less invasive procedure. So Chris talked in the last episode about surgeons starting to treat GERD. That was the only option in the 60s, 70s, 80s, really. And so they would take surgically your stomach and wrap it around your esophagus. We called it a Nissen fundoplication. And this evolved over the years. They call it a toupee now to make it not as tight. And there's different, technical differences between those, but it was invasive. It was surgery. There was potential side effects and complications, but it was really good at controlling GERD. It came with some other side effects like potentially a vagus nerve injury, which led to gastroparesis, which was poor gastric emptying and inability to belch or vomit. This gas bloat syndrome, we call it. And so there was a desire to make a procedure that created more natural anatomy. And if we basically fix the anatomy from the inside, create what's called an angle of His, that's the angle of your esophagus and your stomach, and recreate that, then you would have less side effects and get the GERD control in a less invasive manner. And that's what the TIF was. Now, it's been around for like 12 or 13 years and has gone through multiple iterations. And it wasn't the best technology early on. It didn't have the best results.
Yeah.
And the reason why was it wasn't addressing all the anatomy. So I always use this, and I hope this doesn't look obscene, but you have this valve, round circular muscle that's made up of your esophagus, the top of your stomach called the cardia/fundus, and the esophageal sphincters. And if that's disrupted by a weak sphincter or a big hernia, that you have to repair all parts of it, not just one part or the other, because it doesn't help then. And so we have found that as the TIF evolved, we do it with a hernia repair. And hernia repairs can be done with laparoscopy now, not a big incision, where you can fix a hernia very quickly. A hiatal hernia, just so everyone knows, everyone walks in the door and says, "I think my hernia is acting up." Well, it can be. But it's really just reflux.
Yeah.
A hernia can move up and down. We call it sliding.
What herniates?
So the stomach, the top of the stomach actually goes into your chest cavity. Through, everyone knows about the diaphragm growing up. We learned about the diaphragm splits the lungs from the abdomen. And there's a little opening called the cura, a little triangle, and the esophagus should go through, but really not the rest of the stomach. And so when you get too much of that going up, or sometimes it goes alongside the esophagus, that's called a paraesophageal hernia. That creates even more problems. And sometimes can actually be somewhat of a needed surgery just for that, because it can lead to complications in an older population. And so we've learned over the years that you don't just tighten the valve, you fix a hernia, you do it at the same time, and you create normal anatomy. That's what we're going for, not an alter anatomy where you wrap the stomach around or you put in a magnetic bracelet, which is one technology that's been used. I mean, Chris has a whole list of, just wild esophageal techniques that were used over the years. None of them stood the test of time, really, besides this one.
That's right.
Wow.
That's right.
Okay. Magnetic bracelet.
Yeah.
Yeah, that was called the leg finger.
Yeah, it's still
But like a slip bracelet,
It's still,
Yeah. There was like a small and a large, and you would just semi-customize it. And then
it's a foreign body.
Yeah.
And a place that's not expected, and you get weird scarring and
It can migraine.
anything. There's a rule of thumb that the surgeons say: anything you put outside the GI tract, where does it want to go?
Inside.
Inside. It wants to erode into the GI tract, and we see all kinds of weird things erode in over years, not like immediately.
We've tried all different types of endoscopic interventions to recreate that barrier, that valve. There was a procedure called enterics where we injected a biopolymer all the way around, and you'd have an x-ray. I did a couple, and you'd inject all the way around the LES, the lower esophageal sphincter, and you'd bulk it up with this polymer. And that didn't end well because patients had strokes from the biopolymer getting into their circulation. So it was pulled from the market. Stretta was where we took a device and burned the sphincter to create scar tissue to narrow the esophagus. There was the endoscopic sewing machine.
Yeah, these are before my time.
And then there was the endocinch, which was basically a big clamp that just clamped things tight and tried to, again, close that open hiatus. And so, but you're right. I think the great take home there is this TIF procedure tries to reproduce normal gastroesophageal anatomy, and that's always going to work better long term.
Yeah, it's not for everyone. We select people I don't want to do a procedure that's not going to help you.
Right.
So we have some tests and criteria and things that will make you a good patient to succeed with it.
Well, I interrupted you when you were talking about a hernia. So do you want to continue on after you talked about hernia because you fixed the hernia too.
So yeah, the hernia repair. So we do measurements. We use a Hill classification where you measure size of hernia, really the width of the opening, and that kind of is something you evaluate during an initial diagnostic endoscopy when we're trying to evaluate for what type of technique would be best for you. And we can do what's called a straight TIF on small hernias. Small hernias don't need to be repaired, and that's a Hill class 1 or 2. Larger hernias, they're getting into the 3 and 4 classification. That's something that if you try to do a TIF, it's just not going to work.
Yeah.
And patients may get dysphagia because what happens, you make this bulky valve and all of a sudden that goes in your hernia, into your chest, and now you can't swallow.
Yeah.
And everyone's that angry. I'm upset. Patient can't swallow anything. Surgeon's got to come in. So we've learned over the years, so C-TIF is what we call combined hernia and TIF procedure.
Okay.
Evolved after we realized that. And so this is why I watch technology. I was watching this technology for years. I watched Strata actually as well. That was around when I was starting. And once they figured that out and they started getting really good data, and that's when I jumped in and learned it and went to courses. And I have a background in advanced endoscopy and kind of fell into my wheelhouse. But that hernia repair is done by a surgeon, not me, if it's one of those larger ones. And it's done at the same time, same day. So the surgeon will fix the hernia under general anesthesia. It is in the operating room like you were asking. And then I follow directly and fix the valve without a hernia messing up my repair.
Yeah.
And so we work together as a team. I work with 2 surgeons. We do it at Brookwood Medical Center, and we have a great system. We can do 6 to 8 in a day. My first procedure took me like 75 minutes. That's a lot of anesthesia time for just my part. I'm down to about 15 to 20 minutes now that I've learned and done quite a few. And it's a very satisfying procedure to do because the patients start feeling better immediately. And their recovery time this way is much faster than the full surgical repair, which still is the right choice for some people. Mm-hmm. So I never like to say like there's one thing to fix everyone. We have a kind of a tool belt of options, and let's find the right tool for you, based on what your symptoms and what your anatomy is.
Yeah. So you fix the flap or the valve is what you said?
Flap valve. There you go.
Yeah. Wow.
Yeah.
Med school. But you fix that, and that stops acid from coming up into the esophagus. I'm trying to like get on not y'all's, nerd level.
Maybe we can get fancy like other podcasts and put a picture up here then.
I'll try. Just kidding. Nailed it.
But you're recreating anatomy, the angle of His, the flap valve, we like to call it. And everyone's TIF is a little different. So when I go in, it's not the same thing for everyone. I would kind of judge where I need to put certain number of fasteners or holders and this and that. Everyone's got a little different shape to them.
Yeah. At what point do you decide? You talked about you have a tool belt of options for GERD.
Yeah.
At what point do you decide that medication is not enough?
Yeah, so I work on referrals from like my partners, like Chris Shaver, and a lot of times he's deciding because he's working with the patient first. There's no way I can see all the GERD patients in 13 sites we go to here, and so my partners, they try lifestyle and medication. I don't know if you want to talk about your process when you consider referral.
Well, yeah, typically, so most patients will start out with, usually by the time they get to our practice, a specialty practice, they have already failed lifestyle measures and over-the-counter medications. And often they failed a first attempt at a prescription medication, like a Pepcid, a famotidine, or something like omeprazole, Prilosec, or one of those other 7 types of PPIs. And so we kind of get into, well, why is this patient not responding? It might be that they have that hiatal hernia. And there's so much regurgitation that just the medication alone is inadequate. So that's one reason to send it to Dr. Parikh, is if there's a hernia that needs to be dealt with. And while we're doing that, let's just do an anti-reflux procedure just to try to keep the patient off of medication long term. And then some patients, just for whatever reason, and this is not most, but just don't respond very well to the medication. It just doesn't, there's a certain percentage that that just pharmacologically, they just don't respond well to medication. And we can do tests to confirm that they really have reflux called pH testing. The standard is to do a wireless test for 96 hours. They're shorter, practically speaking. We don't often do 96 hours here in this market, but that's the gold standard. And we can actually, as long as we can confirm reflux, these non-responders would be great candidates for TIF procedure. And then lastly, some patients just say, Doc, I don't want to be on medications every day for the rest of my life.
Yeah.
And I respect that.
Mm-hmm.
I don't like taking medications. And so I'll just kind of give them a discussion of the risk and benefits of medications versus surgery. A lot of times we'll say, let's do, like we talked about before, surgery is a really tried and true, historically proven way to treat reflux. It's not necessarily a failure to treat reflux. It's a really good treatment option in the tool belt.
Okay.
And so those would be the kind of patients I'd send across the hall to Dr. Parikh.
Okay. That's a good answer. Because I was going to say, like, if a primary care doctor or primary care APP is listening, like, when would you want, is that when you would also want them to send to us or TIF?
And, we're checking not just for what else to do for GERD, but let's make sure it's just GERD.
Or, yeah.
We see how much food allergy induced eosinophilic esophagitis. I didn't see it in training much, but man, we see it here like crazy. It's called EOE.
Yeah.
Commonly associated with asthma and atopic dermatitis, eczema. Maybe you have a tumor there. It's fine. Let's not miss that.
Yeah.
And so let's, we kind of dig a little deeper. There's other things that cause chest discomfort that's not GERD. And
Yeah.
not every dental and I love my colleagues, but not every referral they send is GERD.
But it's good that they send to us.
But we need to make sure.
Yeah.
And I think sometimes patients, so the PPI market has been stigmatized by potential serious adverse effects. The big three: fractures, kidney disease, and dementia. And so patients often will bring it up to us is, I'm just afraid of these medications. And that's unfortunate. Look, I'm no defender of pharmaceutical companies, but that's been vastly overblown, the adverse effects of proton pump inhibitor medications. So usually it's completely safe to take even long term, like we talked about last episode. But a lot of times the patients still have that in their mind. They're terrified that they're going to get Alzheimer's from their acid reducer, and they want to talk about other options. And that's appropriate. And it's nice that we have a very minimally invasive way to get them off medications and treat their reflux.
Well, and I asked Dr. Parikh earlier, you do this in the OR, right? Mm-hmm. And that sounds scary because we normally do all of our scopes at a surgery center or in the hospital GI lab.
Yeah.
And so it's not scary.
An hour or two. Yeah.
Yeah.
Exactly.
But tell us why it was in the OR.
It's in the OR because we use general anesthesia.
Okay.
And I would say 90% of our cases are with a hernia repair. That's really the more symptomatic patients. They're harder to control with just meds and dietary lifestyle changes. And so we do both parts in the OR. And certainly for the hernia repair, you have to be under general anesthesia. And for the TIF portion itself. When I do a TIF by itself, I may do it in the GI lab, but it's still under general anesthesia.
Okay.
And I will say, it's good for people to know you stay overnight. It's called an observation stay. So it's not an outpatient procedure per se, like a surgery center, but it's not considered an admission. You go home usually the next morning. And it's really just to kind of, get you hydrated. It's a little hard to swallow liquids the first day.
Yeah.
And by the time the morning comes around, usually you're feeling a lot more comfortable drinking liquids and ready to go. And it's also important for people to know, like, we put you on a pretty strict regimen for 6 weeks of no heavy lifting, a very restricted diet to allow, and we've put everything into place.
Mm-hmm.
It's not going to stay there if all of a sudden you start going and lifting up I don't know, how heavy is your dog? If you start picking up 100-pound dogs, you're going to pop some of those sutures and fasteners and it'll fall apart. And so we have a strict regimen of no heavy lifting and a very strict kind of, it's a boring diet, I tell everyone, but it's worth the 6 weeks of that boring diet for decades of
Yeah.
help.
Everyone
Yeah.
that has like talked to us about having TIF before, they are like the diet terrible after, but like totally worth it.
Yeah.
Totally worth it. You kind of already talked about like who is a good TIF candidate. If somebody were to refer to you for TIF and you're like, hey, probably not the best candidate, who is like not a good candidate?
No, we have to make what we call exclusions where you just can't get it. All the data we've seen is in people with a BMI, a body mass index of under 40. So we kind of use that as a limit right now. There's research going on with higher BMI. And I think the data is looking good so far. It's very preliminary. We want to see, again, before I start doing something like that, I want to see some years of data that is helpful versus doing a surgery. One of the items in the tool belt is my foregut surgeon that does gastric bypass. That'll help with a BMI of 50, and it should generally cure GERD for almost everyone. And so we shouldn't be afraid of bariatric procedures or weight loss surgeries. They're great.
Yeah.
And saved a lot of lives and
Can work alongside GLP-1s too.
Yep.
I had an interesting thought, so a really good treatment for reflux in morbidly obese patients is a gastric bypass, like you just said. Some of the other non-surgical, some surgical approaches like gastric sleeve usually worsen reflux. So that's one thing to point out. And then the GLP-1s will usually worsen reflux. So it's kind of a mixed bag. Some modalities for weight reduction worsen reflux, kind of paradoxically. You would think I'll lose a lot of weight, my reflux is great. That's not the case with GLP-1s and with certain bariatric surgeries. So there is still a role for the gastric bypass, the old-fashioned gastric bypass.
It's a great option in the right hands, experienced foregut surgeon.
Yeah.
There's some other exclusion things like the esophagus we think it's just a food pipe.
I'm gonna start calling it food pipe.
It's a complicated organ. It's got all these muscles. Some are straight, some are circular, and if some of those muscles aren't working correctly, it can manifest as chest discomfort, and it's actually a dysmotility, or the muscle's not moving correctly. And if we do any sort of anti-reflux procedure, whether it's a surgical approach, a TIF approach, some combination, you can really hurt the patient by not allowing them to swallow food normally after the procedure. So that's kind of part of our workup. It's making sure their motility is good and not something that they're going to have a complication afterwards. And so that's another patient that we would exclude. If they have esophageal dysmotility, there's some types that are mild and we can do it on, no problem, but a lot of them will lead to a lot of complications.
Yeah. Yes.
Can I ask a question of the doctor?
Sure.
A lot of foregut surgeries are irreversible.
Yeah.
Is TIF in any way reversible, or is it permanent?
TIF is, I would say that it's what happens, and kind of what I was alluding to earlier, is you need 6 weeks of that scarring to happen. So that's, once it scars in, it's there. But it doesn't prevent you from doing surgical procedures on top of it. The fasteners are removable surgically. There's a lot of scar tissue. It's not easy.
Yeah.
You got to have it in an experienced surgeon's hand. But
even if you remove the fasteners, it's still going to stay relatively thick because of the scar tissue.
Yeah, exactly. And so you can still wrap around the TIF. It doesn't eliminate surgical options. I'll put it that way.
You can still screen or surveillance Barrett's esophagus.
Absolutely. Absolutely. Most of the work is actually using the stomach tissue, not the esophageal tissue. And so you should still have a good view of the Z-line or the connection between the esophagus and stomach.
Double bonus.
Yeah. Walk us through like the day of the procedure, but also like the prep for the procedure, because I know they have to like do a general, I guess, EGD kind of prep.
Yeah, it's a tough one.
Yeah.
Nothing to eat after midnight and done.
Oh, really?
Yeah. Now, there's other things that go into it. It's not that easy for everyone. If you have blood thinners, we're going to hold them.
Yeah.
If you have GLP-1 medication, we hold it because we don't want to intubate you and then all of a sudden we go in and you have a stomach full of food and we have to cancel the procedure. That's terrible.
And a pro tip, don't put Zen, mints, or chew gum.
Yeah.
Or they'll send you home,
Yeah.
potentially.
Any nicotine pouches.
Read the fine print on your prep instruction.
Anesthesia is very particular. And honestly, like the tobacco,
Yeah.
you will have better healing and outcomes with stopping your tobacco use, with your healing process. So the patients come in, they're in the pre-op area, they may be next to a person with just getting heart surgery, but this is nothing. This is the complete opposite of heart surgery. It's a very safe procedure, essentially almost zero serious, what we call SAE, serious advent effect number. Like it's a very safe procedure.
Okay. What surprises? Well, wait. When they get out of their procedure. I almost said surgery, but I guess it is surgery if it's a hernia repair.
We call it surgery, yeah. Well,
what they have to stay the night in the hospital.
Yeah. So the procedure overall may be between the hernia repair, which is 90% of the cases, plus the TIF. With the two surgeons I work with, let me give them a shout out, Dr. Cameron Askew and Brendan Hakes, both fantastic surgeons over at Brookwood that we work with and trust. The whole thing takes maybe 2 hours. So anesthesia time is very low.
Yeah.
And, we've gotten a lot more efficient. We use the same team every time. And so everyone kind of knows everyone's movements and thoughts, and it just speeds up everything. Everything's available. We're not looking for stuff. It's a very well-oiled machine that we've developed over the years. It didn't happen the first 6 months, but now we've got it really down.
Yeah.
And then they'll go to recovery for about 60 to 90 minutes as they wake up from anesthesia. And then they get a room assigned. Me and the surgeon talk to the family after the procedure and tell them what to expect tonight. And they go to their room, and really they just sleep through the night. And we're just focusing on them walking up and down the hallways, sipping on liquids, using the bathroom, keeping them hydrated with some IV fluids. And they go to hopefully get some sleep for a couple hours. It's not the most restful night. And then I usually see them, me and Dr. Hakes and Askew will round between 6 and 8 a.m. and send them home on their way with the very rare indication to stay longer.
Okay. So what is recovery like? We mentioned the diet, but talk a little bit about the diet that you want them to follow after TIF.
Sure. So it's not easy. It's very boring. We have a pamphlet or a booklet that every patient gets that will have day by day, week by week, a shopping list. There's no mystery, and there's no excuse to not follow the diet. And I tell everyone, man, in 3 or 4 weeks, you may be ready to just destroy a pizza, but don't do it.
Yeah.
Please follow this guideline. And it's liquids for the first 2 weeks. That's the hardest part. And then it's different consistency, soft things for the next 4 weeks.
Does a liquid count as smoothies or ice cream?
Yeah. So the first 2 days is clear liquids.
Okay.
The post-op day 1 and 2. And then after that, we get into thicker liquids and soups and things like that. But yeah, besides the evaluation, there's not much prep. And after 6 weeks, I meet you back in the office and we see how you've done. Sometimes we'll interact in between if they're having any issues, but typically they'll see the surgeon 2 weeks after the procedure, check on their laparoscopy if they had hernia repair. And then I'll see them in 6 weeks. And we keep you on your acid reducers the whole time. And when I see you, as long as you're doing all right and you're eating okay, I'll start to wean your acid reducers off. And it's I'm not gonna lie, some people I do a lot of complicated stuff, a lot of cancer care, but we get a patient back for that second follow-up and they're like, man, I've been eating all the pizza and drinking all the wine I want, I never touched. It's really they're really happy, and the quality of life is great. It's very satisfying. Now then I have to tell them hey, listen, that's not a hall pass to eat whatever you want. You gotta still be healthy.
Yeah.
I'm still stuck on no pizza for 6 weeks.
It's
It's
hard.
That would be hard for me.
Yeah, I usually tell people they're gonna lose 8 to 10 pounds.
Can I have TIF? I'm just kidding.
Post TIF, and not everyone, but most people need to lose that 8 to 10 pounds.
Yeah.
And I said just keep it off after the TIF. Don't go back to that.
What surprises your patients the most about this procedure? That have had it?
What surprises them probably at that the recovery wasn't that bad, in terms of like pain and nausea. Like they get over that within the first few days pretty quickly.
Okay.
I think what surprised them the most is that the second most common thing is that they all think, not all, but most patients think like, oh, I can swallow anything now after a couple of days. And they do, a lot of people try. And they're like, oh man, I got that thing stuck and it was painful getting it down. And like I told you, but we're human, right?
I know.
What's one thing you wish every GERD patient knew?
Yeah, that's a good one. You want to
Either of y'all, I mean, yeah.
top of your head?
Well, one thing is that every GERD patient knew is I would say that if you have chronic symptoms, that's not normal and you don't have to suffer with them. And let's have a discussion about them in our office and talk about treatment options, which may include medication for a little while or a long time, or some procedure like a TIF procedure.
Yeah. I would add, kind of along the lines of what Chris just said, is not all GERD should be like if you have intermittent symptoms and they get worse, like don't ignore that.
Yeah.
Let's get checked out. There are things that GERD can cause or different diseases that mimic GERD, and let's make sure we got the right diagnosis.
There have been quality of life studies comparing GERD to other disease states, including severe depression and CHF, and GERD ranks as high in diminished quality of life as some of those other chronic diseases. That's well documented.
Wow.
So it is a quality of life killer, like legitimate chronic GERD. It's very uncomfortable. It can interrupt sleep.
Mm-hmm.
Interrupting sleep is bad for lots of things, including mood, including longevity. So it's something we really need to address, not to mention reference the esophageal cancer special edition flush and look at that and talk about kind of some of the horrific, again, most reflux patients never get esophageal cancer, but it is a primary risk factor. So
it is while we're seeing decreasing rates of colon cancer, some other cancers with screening, esophageal cancer is not one that we're winning yet.
Yeah.
We got a long road on that one.
Yeah. What's been your most memorable TIF patient success story?
Oh man. Yeah, I did a webinar through our practice, and it was kind of spreading the word to referrers and patients at Birmingham Gastro. And I had a patient that I did early on. It was a straight TIF, meaning no hernia repair. It was actually a patient that had one of the surgical techniques initially. Okay. And it loosened up over time. And, I'd been marketing and advertising around town, like, hey, I'm doing this, like, send me your patients for evaluation if you want to look at another approach. Because if Nissen or Toupee, which is the surgical types, get undone or loose, then you have to do another surgery to fix that. But TIF is a great modality for someone that has a loosened surgical procedure, as long as it's not a big hernia again, which can be a problem then. But if that's the case, then I can just go in and tighten it with a TIF, which is wonderful. And one of the first patients I did was that.
Yeah.
And she, we prevented surgery, and this woman was so like Southern bubbly, like happy person already. And she was my spokesperson for like the next year, and she did so well. And she talked about in the webinar, like, again, all the things she was eating excessively probably, but she was so happy. And it's a great memory I've had. And I kind of see her occasionally for other routine GI care. And
yeah.
It's great to see that.
I think my favorite story, and I only know 2 people that have gotten it that I've actually talked to, is the primary care provider.
Oh, yeah.
When we did the lunch at their office to talk about TIF, and she comes up to me and she was like, TIF, like, changed my life. And I was like, you want to be on a video? Like, you because I didn't love her for that. No, but she just spoke so highly of it and spoke so highly of you. And it's like I try to give all of my patients that have chronic GERD, like, send them to Birmingham Gastro. So I loved that because
there's good options out there, and TIF is not the only one. there's a lot of, actually, I just came back from this conference where I learned some new techniques where.
Are you trying to learn them now? For real, you're going to get
No, I went to the training course already, so
Okay.
there's new stuff. And it affects, God, how many, if we say 20, there's 50 million Americans. I don't know.
It's a lot of American.
Or you get it. And so we have to have ways that are easy and reasonable to do without side effects to meet the needs of our patients and community. So
let me ask you that. Go ahead.
Oh, and you won't find many GI doctors that have done more than 500.
Yeah.
So
he's the
how many that your doctor has done is extremely important. And so Dr. Parikh has a ton of experience with this procedure. So no procedure is without risk in anybody's hands, but that really mitigates risk and promotes good outcomes when you have a very experienced endoscopist. So shameless plug again for Dr. Parikh.
Appreciate it.
Yeah.
It's the whole team though. Like we really have a whole team that works great together.
I want to go
to my practice. I'm just kidding.
When I first started at Birmingham Gastro, I wanted, like I sat in on colonoscopies, I sat in on EGDs, I was in clinic with you, like shout out y'all. I wanted to do
With those fashion scrubs you have.
fashion scrubs. Everybody wears the scrubs. Duh. I immediately went and bought scrubs when I found out I was going to be in the
Like, who is this person?
Well, both of y'all judge me when I wear scrubs. Y'all look me up and down. You're like, oh, you wear that? That's what you said one day.
We don't wear scrubs.
Well, I didn't want to get anything on me. When I first sat in on scopes, somebody was like, oh, you should wear like closed-toed shoes. And I was like, why? And then they were like, something might get on you. And I said, something might get on me? And immediately I went and bought scrubs that night because I was like, I'm not taking chances. And
we call that a code brown.
I know. Well, then I was sitting there with Passarella and I was like terrified the entire time. And so every time the nurse would move, I would like scoot my chair to and from because I was so afraid. And he was like, what are you doing? And I was like, somebody told me that something was going to get on me. And he was like, I would definitely warn you. And he was like, that doesn't really happen. He said, be glad you were here on Monday. And I'm like, oh, I would have passed away. Anyways, but I did want to go into the OR. But remember, we tried that and that just didn't work out.
TIF Tuesdays, we call it.
TIF Tuesdays. I had to fill out a bunch of paperwork that
Everyone in the OR, I tell them, don't wear your fancy watch. We wear G-Shocks.
Oh.
Waterproof. It's good.
Yeah. Let me ask this question because people might be thinking like, oh, got chronic GERD. If somebody's had GERD or heartburn or acid reflux for a year, would you say they're a TIF patient?
Well, no, I wouldn't say right off the bat. I'd say let's try to optimize
through your full belt of other options.
Of the millions and millions of people with GERD out there, I would still say only a small percentage need some sort of procedural work.
Like somebody that's had GERD for how long? Like define chronic.
I have a great example for you. So one of the things I do is ablate Barrett's tissue that's very long in the esophagus or has cells that are becoming cancerous. And so we want to stop that progression from what we call dysplastic Barrett's to cancer. And so great, I can do that. Sometimes it's a 40, 50-year-old person and they've been on omeprazole for 20 years and they develop this on omeprazole. That patient is not well controlled, even though the heartburn may be well controlled. And so this is someone that's had it for years. They almost got cancer despite the meds and lifestyle stuff they did because of their anatomy. No fault of theirs. Sometimes there's family genetics and just different molecular biology of their cells that are more aggressive than other people. I think we can assume in younger people there's some different biology there, genetics potentially. And so I said, hey, let's not just eliminate this abnormal cells. Let's also fix the problem that caused it in the first place. That's a great kind of option. Someone that had TIF for a while, GERD for a while, are feeling good, but you want to repair their anatomy to prevent cancer. Now, if you've got GERD for a year and you tried some over-the-counter meds and maybe you do an endoscopy, we don't see any alarm things, and we control you. No, I don't recommend a TIF.
Yeah.
But,
Okay. Well, anything else you want to say about TIF?
I'll give you some numbers. I'm a numbers guy.
Yeah,
I like that. 5-year data, 86 to 88% of people are off prescription meds. So it's, what Dr. Shaver said earlier, we want to see lasting benefit.
Yeah.
We're now collecting 10-year data, 7-8-year data is out, and we're still right around that 80% number. And so it's not forever.
Yeah.
Most people, it lasts a long time, we're seeing. But there are ways now, which is the new technique I just learned, it's called ARM.
Mm-hmm.
ARM stands for anti-reflux mucosectomy, where I can go in and either I can tighten up the valve again with a TIF, no surgery involved, just the endoscopy, or I can actually ablate some of the tissue around the TIF or valve and just make it just a little bit tighter if it loosened up a little bit, because things stretch over time. Yeah.
And one important point too to highlight is durability of the procedure. You said 7 or 8 years. I'm assuming that compares favorably to standard minimally invasive surgery for reflux.
Yeah, so the data is only to about 7-8 years right now. We're getting 10-year data right now, and hopefully I'll publish in the next year.
Do you predict it will be similar to what we see with durability of conventional surgery?
Well, that's what we're comparing it to.
Okay.
That is currently the gold standard.
You don't, not sure, but is the trajectory
It's looking good.
okay?
It's looking good. Yeah.
All right, that's important to know.
And the best thing is it's easier to tighten. We have multiple modalities to tighten it if it gets loose.
The arm
or a repeat TIF. Without surgery.
Okay.
Redoing a Nissen or Toupee surgical anti-reflux procedures, it's definitely more complicated.
Does doing the TIF after the hernia repair, does that reduce the risk of the hernia reforming over time or no?
If during the hernia,
sometimes hernia repairs can fail.
Yes.
Does doing a TIF with a hernia repair make the hernia repair more durable?
No.
Okay. So you can still recur the hernia at the hernia.
So I've had a few patients with recurrent symptoms a few years out, and so we'll reset
the TIF may be intact.
TIF can be intact, and these are usually the bigger hernias.
Okay.
And so the surgeons like to avoid using something called mesh, if possible. But if they do recur and they need a revision of the hernia, not the TIF, which is usually the case, then they'll put in a mesh the second time.
Okay.
Well, thanks.
Staffing out GERD, one patient at a time.
Yeah. I feel we're really way over. And so are y'all going to kick my butt if we play this game for 2 seconds?
I got to.
Okay, bye. Okay.
But if you want to do it at the office and then...
We'll do it another time. It's fine because it is late. But thank you, Dr. Parikh, for being on, on the Flush. You're the first doctor visitor we've had. So...
hopefully the first of many.
Yeah, if they...
We have so many now.
All of them are acting like they're not going to be on it, but you will be on it. Okay? All of you, including one Arishi Agarwal.
Good luck with that.
I'll go to his house. I'm just kidding. No, but thank you for being here. Thanks for what you do. Thanks for making BGA great, both of you.
We appreciate you too, Julianna. This is great.
Thanks.
This is getting the word out. That's hard to do sometimes.
Yeah, it is. Any closing thoughts?
No, just come see us at Birmingham Gastro and talk about reflux. I have reflux. It's no fun. But we definitely can treat you and improve your quality of life.
Yeah.
Just reach out to us.
I have a request. If we can get like a BGA branded mints or gums.
Okay.
I'm all in.
I'll get it. I'm on it.
For ELP1 and GERD patients.
Okay. I had butt wipes that I put a sticker on and I give them out at events. So I need to actually get them branded so I don't have to put a sticker on them because it's a lot of time. But butt wipes and mints we're in.
I'm going to guess the mints and gums will be more popular.
I don't know. Everybody goes for the butt wipes. Like I completely run out. But anyways, thanks for being here. Remember, if you do want to book an appointment to talk to any of our physicians or any of our APPs about your acid reflux, GERD, go to bgapc.com and you can schedule a clinic appointment online at any of our 13 locations. And we'd love to be able to help and talk through all of your issues, GERD or any digestive issues that we can help you move forward in life with. Because we are GI Care that moves you forward. But anyways, thanks for listening to The Flush, and we'll see you next time.